Hello, this is Eric Strong from Stanford University and the Palo Alto VA Hospital, and this lecture will be discussing the diagnosis of chamber enlargement on EKG. Here are the learning objectives of this lecture. First, to understand how chamber enlargement and hypertrophy influences the morphology of EKG waveforms. And second, to be able to identify right and left atrial enlargement and right and left ventricular hypertrophy. Before I begin, I want to point out that the biggest source of frustration medical trainees face with diagnosing these conditions on EKG are memorizing long lists of individual criteria. While I will be reviewing many of these criteria, it's important to realize that there is great variability between providers as to which specific criteria are used in practice, and none of the criteria are particularly sensitive and specific. In general, understanding the pathophysiology of the changes of chamber enlargement will allow you to predict indicative EKG features, which will partially alleviate the need for memorization. Before I discuss the specifics of EKG diagnosis of chamber enlargement, I want to highlight the differences between the terms enlargement and hypertrophy. Usually, enlargement refers to increased chamber size, whereas hypertrophy refers to an increased chamber wall thickness. Although it is sometimes suggested that enlargement is from volume overload and hypertrophy is from pressure overload, this dichotomy is overly simplistic and should be avoided. Unfortunately, the EKG is poor at distinguishing enlargement from hypertrophy, which generally requires cardiac imaging such as echocardiography or MR. In common practice, when the EKG is findings suggestive of increased muscle mass, atria are referred to as enlarged, while ventricles are referred to as hypertrophied, irrespective of the actual physical changes of the chamber. In addition, if this wasn't confusing enough, atrial enlargement is sometimes called atrial abnormality to emphasize the perceived lack of specificity of the relevant EKG findings. The first step to understanding the EKG changes from atrial enlargement is to understand that there exists a P-wave axis in the heart analogous to the more familiar QRS axis. While the QRS axis is a measure of the vector sum of the waves of depolarization of the ventricles, the P-wave axis is a measure of the vector sum of the waves of depolarization within the atria. Because of the relatively small amplitude of the P-waves, manual determination of P-wave axis can be very difficult, but luckily modern EKG machines will usually calculate this for you and can do so with a fair degree of accuracy. It is usually listed in the upper left of the EKG printout next to a line that reads PRT axes. And yes, there is a T-wave axis as well, which will be discussed in a future lecture. What is the normal P-wave axis? To answer this, let's look at cardiac anatomy from a frontal view. This will represent the right atrium and ventricle, and here is the left atrium and left ventricle, which lies to the left and posterior. The sinus node sits high in the wall of the right atrium near the entrance of the superior vena cava. And here this will help us orient the heart relative to the chest wall. Finally, let's now overlay Einthoven's triangle with its classic three bipolar leads. Lead 1 measures the potential difference between the right arm and left arm. Lead 2 measures the difference between the right arm and left foot. And lead 3 between the left arm and left foot. We can see that from this viewpoint, the bulk of the right atrium lies inferior to the sinus node. Remember, by convention, vectors pointing right to left from a frontal view are designated 0 degrees, while vectors pointing straight down are designated positive 90 degrees. So right atrial depolarization occurs in a direction of roughly positive 90 degrees. The bulk of the left atrium lies to the left and ever so slightly inferior to the sinus node. Therefore, left atrial depolarization occurs in a direction just inferior to 0 degrees. The net direction of depolarization, that is the P-wave axis, is the vector sum of these two components weighted according to the relative masses of the chambers. As a consequence, the P-wave axis is normally between positive 30 and positive 75 degrees. Note that this is roughly in the same direction as lead 2. This will be relevant in a moment. So what happens in the setting of right atrial enlargement? If the right atrium is relatively more massive than the left, it has a greater influence in the net direction of depolarization, and the P wave axis shifts inferiorly. A P wave axis rightward of positive 75 degrees is suggestive of right atrial enlargement. In the setting of left atrial enlargement, the opposite happens, and this is suggested by an axis shift leftward of positive 30. Unfortunately, changes in P wave axis have poor sensitivity and specificity, particularly for left atrial enlargement, and I would avoid using the P wave axis as a sole factor in making this diagnosis. As I just mentioned, the P wave axis tends to lie roughly parallel to lead 2. Therefore, the P waves in lead 2 should always be positive in sinus rhythm, and are generally the most prominent P waves in the EKG. Since the P waves in lead 2 are the most prominent, they are also a great place to look for changes in the morphology that can suggest atrial enlargement. This task is made easier by the fact that right atrial depolarization precedes left atrial depolarization ever so slightly on account of the sinus node's location in the right atrium. Here is a picture of a typical P wave as it might appear in lead 2. The area under the curve, that is the area bounded by the waveform, roughly represents the relative mass of the atria. Since the sinus node is in the RA is depolarized first and the LA second, and thus the first portion of the P wave is from right atrial depolarization and the second portion is from left atrial depolarization. Therefore, in the most general sense, right atrial enlargement affects the first half of the P wave and left atrial enlargement affects the second half. In right atrial enlargement, the increased mass leads to greater voltage and a greater duration of time over which the depolarization occurs. Here is left atrial depolarization unchanged. You can see that there is substantial overlap now of the timing of the depolarization of these two chambers. As a consequence, the P wave in right atrial enlargement tends to be unusually tall. The specific cutoff that most clinicians use is greater than 2.5 millimeters, which is 0.25 millivolts. Things are slightly different in left atrial enlargement. Here is the normal contribution to the P wave from a normal-sized right atrium. And now here's the contribution from the more massive left atrium. Since left atrial depolarization initiates later to begin with, the P wave ends up being overall prolonged. The typical cutoff is greater than 120 milliseconds. You will also note that the P wave in left atrial enlargement may have two distinct peaks, the first from the right atrial depolarization and the second from left atrial depolarization. Another effect of atrial enlargement on the EKG can be appreciated in the precordial leads, specifically lead V1. Here is the heart lying in the chest as seen in axial cross-section. The sinus or SA node, for sinoatrial, is located approximately here. Strictly speaking, the sinus node lies superior to this particular plane. However, this graphic is obviously just an approximation of the anatomy. Here are the precordial leads V1 through V6. What does the P wave normally look like in V1? Remember that right atrial depolarization occurs first, which is directed towards the V1 lead. Therefore, the initial deflection in V1 is positive. Next, left atrial depolarization occurs in a direction away from V1, and thus the second deflection is negative. This convenient separation of the right and left atrial components makes V1 another great lead to interpret atrial activity. In right atrial enlargement, there is greater depolarization towards V1, while the depolarization away from V1 is unchanged. Therefore, the initial positive deflection is unusually prominent. One cutoff used in the literature for the unusual prominence is a height of 1.5 millimeters. However, a much more commonly employed cutoff in practice is an area under the curve of greater than one small box, which is technically 4 millivolts milliseconds. In left atrial enlargement, the opposite occurs. The initial positive deflection towards V1, which represents right atrial depolarization, is normal, while there is an unusually prominent negative terminal deflection. Analogous to previous, the cutoff for pathology is an area under the curve of greater than one small box. This chart summarizes the EKG findings of atrial enlargement. For right atrial enlargement, the P wave in lead 2 can be taller than 2.5 millimeters. The initial positive deflection in V1 can enclose an area greater than one small box, and the P wave axis can be shifted rightward of 75 degrees. For left atrial enlargement, the P wave in lead 2 can be longer than 120 milliseconds and double peaked. In V1, the terminal negative deflection can be greater than one small box, and the P wave axis can be shifted leftward of positive 30 degrees. Keep in mind that most people with demonstrated atrial enlargement of some kind do not necessarily or even usually satisfy all relevant criteria. This chart is adapted from a great study in which the accuracy of EKG criteria for atrial enlargement was measured using cardiac MR as a gold standard. As you can see, the criteria for right atrial enlargement was poorly sensitive and highly specific, while the test characteristics for left atrial criteria was more varied. I don't want to confuse you with biostatistics, however, I'd like to note that the fact that right atrial enlargement is less common than left means that the positive predictive value of the EKG findings for right atrial enlargement are actually not as dramatically different from left as their different specificities would suggest. In other words, there are definitely patients that you will encounter who have EKG evidence of right or left atrial enlargement whose atria appear normal on imaging. Ventricular hypertrophy. Analogous to how the P wave axis can be shifted by atrial enlargement, the QRS axis can be shifted by ventricular hypertrophy. Here is the heart as viewed in the frontal plane again, and we'll now add in one additional aspect of the conduction system, the AV node and the His-Purkinje system, represented by a narrow yellow band. Ventricular depolarization originates from the Purkinje fibers, such that net depolarization within the right ventricle is directed down and slightly to the right, while net depolarization within the left ventricle is directed slightly up and to the left. The overall QRS axis lies somewhere between, with a relatively wide range of normal spanning negative 30 to positive 90 degrees. In right ventricular hypertrophy, the extra muscle mass in the RV shifts the QRS axis rightward, while in left ventricular hypertrophy, the extra mass in the LV shifts the axis leftward. As with shifts in the P wave axis as a sign of atrial enlargement, an axis shift as a means to identify ventricular hypertrophy when viewed in isolation is both insensitive and nonspecific. The best means to identify ventricular hypertrophy is to examine changes in the QRS amplitude in the precordial leads. Here is the heart in axial cross-section again, and here is our AV node with the His bundle, and this time with the right and left bundles. Let's examine the typical QRS complex in V1 and V6 in normal hearts, RVH, and LVH. In normal hearts, the initial phase of ventricular depolarization is a left to right wave of depolarization across the intraventricular septum. This results in an initial upwards deflection in V1 and an initial downward deflection in V6. This initial downward deflection is sometimes referred to as a physiologic septal Q wave as an acknowledgement to its origin. In reality, the source of this deflection may be more complicated than this, but this simplification is sufficient for understanding EKGs. After that initial deflection, right and left ventricular depolarization occurs nearly simultaneously. As the muscle mass of the left ventricle is normally much greater than that of the right, the net vector of the main phase of ventricular depolarization is directed away from V1 and towards V6. Thus, V1 registers a deep negative deflection, and V6 registers a tall positive deflection. Hypertrophy of the right ventricle changes the relative balance between the two main depolarization vectors. Now the net direction of depolarization is towards V1 and away from V6. Therefore, V1 records a tall R wave, while V6 records a deep S wave. In LVH, the vector towards V6 is of even greater amplitude. As a consequence, the S wave in V1 is deeper and broader, and often lacks the initial upwards deflection, and the R wave in V6 is taller and broader, and often lacks the initial physiologic Q wave. One can summarize these findings by saying that in the precordial leads, RVH causes the QRS complex directionality to be the inverse of normal, while LVH causes the QRS amplitude to be more pronounced but in a normal direction. As leads 1 and AVL run in the same general direction as V6, often the same findings we see in V6 here in both RVH and LVH will be present in those limb leads as well. You may have noticed that the ST segment and T wave for some of these QRS complexes appear a little unusual, which brings us to the next topic. Secondary repolarization abnormalities are changes in the sequence of ventricular repolarization that are a consequence of either abnormal anatomic structure of the ventricles or an abnormal sequence of depolarization. In ventricular hypertrophy, they consist of a downsloping ST segment and T wave inversion. They are most commonly seen in leads over the hypertrophied ventricle. This was formerly known as a strain pattern because it was felt to be secondary to an overworked ventricle trying to pump against excessive afterload. As with many prior beliefs in medicine, reality has proven to be a bit more complicated, so usage of the term strain pattern is no longer recommended. Here's a picture of a normal QRS complex that might be seen in a lateral precordial lead, that is V5 or V6. And here is a picture of a QRS complex in those leads in a patient with LVH. You can appreciate the depressed and downsloping ST segment, which then leads right into an inverted T wave. Other causes of secondary repolarization abnormalities include bundle branch blocks and pre-excitation, which will be discussed in other lectures. Yet another aspect of the ventricular depolarization that can provide evidence of hypertrophy is something called intrinsicoid deflection. This is the duration of time from the beginning of the QRS complex to the peak of the R wave. It is typically only measured in the precordial leads. Normal is less than 35 milliseconds in V1 and less than 45 milliseconds in V6. Here is a normal QRS complex, which only appears wide because we've zoomed in quite a bit. Here is the intrinsicoid deflection from the beginning of the QRS complex to the peak of the R wave. In this case, it is about 35 milliseconds. And here's an abnormal QRS complex where the intrinsicoid deflection is prolonged, in this case about 60 milliseconds. An increase in intrinsicoid deflection is just one more piece of evidence of ventricular hypertrophy, usually left ventricular hypertrophy. Let me now summarize the EKG findings of ventricular hypertrophy. First, unusually tall R waves plus or minus secondary repolarization abnormalities are found in V1 and V2 in RVH, and in 1 AVL, V5, and V6 in LVH. An unusually deep S wave is seen in 1 AVL, V5, and V6 in RVH, while it is seen in V1 and V2 in LVH. RVH can deviate the QRS axis rightward a positive 90. LVH can deviate it leftward of negative 30. Although I haven't previously mentioned this, because right and left ventricular hypertrophy often go along with right and left-sided heart failure respectively, RVH is also associated with findings of right atrial enlargement, while LVH is also associated with findings of left atrial enlargement. Conduction abnormalities, which are covered in another lecture, can also be present and may be either complete or incomplete. Finally, RVH is frequently associated with poor R-wave progression or even reverse R-wave progression, while LVH is associated with delayed intrinsicoid deflection. As mentioned at the beginning of this lecture, often when learning EKG diagnosis, trainees are focused on memorizing specific diagnostic criteria. When it comes to RVH, while various diagnostic criteria have been suggested and published, none are commonly employed in clinical practice. Instead, an EKG diagnosis of RVH is based on a subjective assessment of the aforementioned common findings. Not all need to be present for RVH to be suggested. In general, diagnosing RVH on EKG by subjective impression has high specificity but poor sensitivity. There is a distinctive variant of RVH seen in COPD, sometimes referred to as the pulmonary disease pattern. The unique set of findings are a consequence of hyperinflated lungs and a physical shift in how the heart lies in the chest. In addition to the typical findings of RVH, also present can be low voltage, a small R wave followed by a deep S wave in all precordial leads, and an extreme QRS axis. The last of these features is particularly uncommon. Unlike RVH, LVH has a large number of diagnostic criteria. In fact, there are too many to reasonably try memorizing and are without universal or consistent clinical application. The sensitivities and specificities vary widely depending on clinical scenario. For example, the sensitivity of one specific criteria may be very different depending upon whether a patient's LVH is due to systemic hypertension or due to hypertrophic cardiomyopathy. As with RVH, the EKG is generally more specific than it is sensitive. It's interesting to note that nearly all studies were done before echocardiography entered into common usage, and many therefore utilized LV mass measured directly at autopsy as the gold standard. I'm going to review the three most commonly used individual criteria for LVH. First is the Sokolow-Lyon criteria. According to this, LVH is diagnosed when the S wave in V1 plus the R wave in either V5 or V6 exceeds 3.5 millivolts or 35 millimeters on a standard EKG tracing, or when the R wave in V5 or V6 by itself exceeds 2.6 millivolts or 26 millimeters. The Cornell criteria is sex-specific and states that in men, LVH should be diagnosed when the R in AVL plus the S in V3 exceeds 28 millimeters, while in women it should be diagnosed if this sum exceeds 20 millimeters. As you can see, both of these criteria utilize only QRS amplitude in diagnosis. To address the observation that many other EKG findings can be present in patients with true LVH, Romhilt and Estes developed a point system. As you can see, various features on the EKG are given either 1, 2, or 3 points. If the total score is 5 or more, they suggest that LVH was essentially definite, while if the score is 4, LVH was probable. While both literature and my personal experience suggest that the Romhilt-Estes score is more accurate than other criteria, the modest diagnostic benefit may not be worth its cumbersome nature. Finally, there are some additional factors affecting the diagnosis of LVH by EKG. First, there are factors that increase the sensitivity of the EKG but decrease the specificity. That is, factors which increase QRS voltage irrespective of the presence or absence of LVH. These include younger age and male gender. The effect of age is significant enough that many cardiologists won't attempt to diagnose LVH in patients under 40 years unless the EKG findings are profoundly abnormal. Then there are factors which decrease sensitivity but increase specificity. That is, factors which decrease QRS voltage irrespective of LVH. These are older age and female gender, as well as obesity, COPD, and pericardial and pleural effusions. At this point, I'm going to review 6 example EKGs to allow you to test yourself to see how much you've learned. After I show each EKG, I suggest that you briefly pause the video so that you can interpret it first before I reveal the diagnosis and explanation. Here is example 1. This is an example of right atrial enlargement, as might be seen in tricuspid valve disease. The key feature making the diagnosis is in lead 2, which I will enlarge. Remember that an abnormally tall P wave in lead 2 suggests right atrial enlargement. In this case, the P wave height exceeds the 2.5 millimeter cutoff that is typically used and cited. Here's the next example. This is left atrial enlargement. Once again, we'll zoom in on lead 2. Although the amplitude of the P wave is low, the duration is just over 120 milliseconds, and it has a very distinctive double peak indicative of left atrial enlargement. This is left ventricular hypertrophy. There are a whole collection of features to note here. First, there are tall R waves in leads 1, AVL, V5, and V6, with secondary repolarization abnormalities. There is a relatively prominent S wave in V1. The QRS axis is leftward deviated, probably around negative 45 degrees. And finally, and this may be easy to miss, if we look very closely at the QRS complex in the lateral precordial leads, and we look at the intrinsicoid deflection, that is the duration of time from onset of the QRS to the peak of the R wave, we see that it is somewhere between 50 and 60 milliseconds, which is prolonged. This is right ventricular hypertrophy. We see the tall R waves in V1 and V2, with a mild T wave inversion in V1. In 1 and AVL, we see relatively prominent S waves. Finally, there is right axis deviation. The axis in this case is probably about positive 120. There's more than one diagnosis here, as we have both left atrial enlargement and left ventricular hypertrophy. Zooming in on V1, we see that there is a very prominent negative terminal component to the P wave, which encloses an area greater than one small box. Although we don't see the prominent secondary repolarization abnormalities that were present in the previous example of LVH, the QRS voltages are still elevated. For example, if we look at AVL and V3, we can see that the patient satisfies the Cornell criteria for LVH, irrespective of whether the patient is a man or woman. And if we look at V5, we see that the R wave is greater than 26 millimeters, one of the Sokolow-Golian criteria. I won't go through it in detail, but this patient also clearly meets criteria using the Romhilt-Estes scoring system. And finally, here's the last example. This is biatrial enlargement. In lead 2, we see an unusually tall P wave indicative of right atrial enlargement. And in V1, we see a prominent negative terminal deflection in the P wave indicative of left atrial enlargement. There are a number of other findings here that we have briefly mentioned along the way during the lecture. For example, the QRS axis is borderline rightward shifted, being around positive 90. The QRS voltage is relatively low, and there is poor R wave progression, with the QRS complex in V6 having an S wave that is as deep as the R wave is tall. Overall, while it doesn't strictly diagnose RVH, the constellation of all these findings still suggests this patient suffers from COPD. That concludes this lecture on chamber enlargement, which I hope you found useful. Please feel free to leave comments and questions.